conference is now being recorded.
Welcome to the J.E. Ryan and Associates webinar, A Brave New World, Understanding the New Requirements of the Medicaid-in-Education. Your presenter for today's program is Kelly Jacoby from New York State Education Department. Operator assistance is available at any time during this conference by pressing #. A question and answer session will follow the presentation. You may send chat questions at any time during the presentation using the chat window, indicated by a speech bubble icon located to the right of the presentation. I will now turn the call over to our speaker, Kelly. Please begin.
Good afternoon. My name is Kelly Jacoby, and I'd like to welcome all of you to the New York State Medicaid Compliance webinar. We'll be discussing today the contents of the compliance agreement, and we'll also talk about the documentation requirements for the new State Plan Amendment 0961. Jacqueline mentioned questions and answer discussion after the presentation, but please feel free throughout the presentation to submit any questions you have, and I will do my best to answer those in a timely fashion. I have never done a webinar before. This is my first webinar, and I have really good instructions, so I think this is going to go very smoothly, but just bear with me. And as I said, welcome to our training. We have to train all relevant employees who have a role in the School Supportive Health Services program. We anticipate tens of thousands of people that will attend our training either face-to-face or we have developed an online training that we're hoping will be available to providers within the next couple of weeks. It's just going through the fine-tuning, testing stages right now, and then it will finally have to be approved by our compliance officer before we can go live with that. So there will be two ways that relevant employees can get their training, and that will be through a face-to-face, and that face-to-face training will be mandatory for all business officials, CSE directors, and billing clerks. However, servicing providers will be able to take the online training or attend face-to-face if they so choose to do that. Most of you know there are 3 departments in New York State government that have a role in the School Supportive Health Services program. That would be the State Education Department, which is the department that I work for, and it is our role and responsibility to implement this program, to share with you all of the requirements in order to bill Medicaid, and we are in charge of setting the special education policy. The Department of Health, Office of Health Insurance Programs, or OHIP as we like to call them, is in charge of setting the Medicaid policy, and we work very closely with them. We've worked very closely since, I believe, July when the settlement occurred, and we had to develop a new state plan amendment, and we're in the process of developing the handbook, but the training materials that we're sharing with you now, and we have a questions and answers that is sort of to be used as our policy, our Medicaid policy, until our handbook is developed. And they're also in charge of the payment methodology. The Office of Medicaid Inspector General, you might know some of the folks there. They used to be our policy office. They're now full-fledged auditors, and they will be out auditing the School Supportive Health Services program. So our agenda topics today are how did we get here? We're going to discuss or clear up some confusion between the New York State Compliance Agreement and the OMIG Compliance Program. We'll talk about the documentation requirements for the Medicaid State Plan Amendment. And we have contact information at the end of this presentation for you. Before we get into the contents of the presentation. There are handouts also. I'm not sure if they were provided to you, the handouts that go along with our presentation. If you don't have the handouts in front of you, we'll talk about them in general, but I would urge you to print the presentation and the handouts that are available on our website, and that link will be made available to you at the end of this presentation. So how did we get here? In 2002, the federal government came in and audited our program, the School Supportive Health Services Program, based on a false claim accusation. What they discovered was significant lack of documentation for services that were provided, and that the services were provided by providers who were not qualified to bill under the Medicaid program. So they were probably qualified to provide the service, but not to bill for Medicaid. And the federal government also discovered that the state did not provide enough oversight to the districts and counties on what documentation was needed in order to bill for this program. So as a result, in July of 2009, 7 years later, the state reached a settlement with the federal government agreeing to pay back $541 million. And if you can believe it, that $541 million was based on 100 sample claims, mostly speech, a few transportation. And with that significant lack of documentation, provider qualifications, and oversight of the program, through whatever rate-setting methodology they used, they came up with, they came up with a sum of over $1.2 billion that they were trying to have us repay, and we settled on $541 million. We also agreed to develop a new state plan amendment, and we developed a compliance agreement with the federal government, and we'll be talking about the components of the compliance agreement. Before we talk about the components of the compliance agreement, I just want to clear up a little bit of confusion that's been going on with the districts and the counties, not so much anymore, but back in October of 2009, because a lot of the New York State's compliance agreement and the OMIG compliance program were kind of implemented around the same time period. But the New York State compliance agreement, you kind of want to think of that just at the state level. It was established to prevent fraud and false claims billing. We are the only state that has a compliance agreement with the Centers for Medicare and Medicaid Services. Further in this presentation, I'm going to give you a link to the OMIG's website where you can view a webinar, if you have not already, by the Inspector General. And in that webinar, he discusses that we are the only state to have a compliance agreement. However, we are kind of the role model now, and other states will be following suit as they are being audited, and it may become policy, a requirement for districts to have a compliance agreement with the Centers for Medicare and Medicaid Services in order to bill Medicaid. So basically, the New York State Compliance Agreement was established to prevent fraud and false claims billing. We'll discuss the components of the compliance agreement after this slide. The OMIG compliance program is for any entity, districts, counties, clinics, hospitals, any entity that's billing Medicaid in excess of $500,000 gross claims. So if you're below the $500,000 gross in a 12-month period, it's not mandatory that you have a compliance program through OMIG. However, we feel that it is best practice to be in compliance, to have that program, and just so you have everything is shored up in case of an audit, in case case anyone comes in, it will kind of it will alleviate the chances of somebody in your district or county filing a false claims accusation against your district. And we'll talk about that a little further. So the components of the New York State Compliance Agreement are listed here. We had to adopt two policies, the New York State Commitment to Compliance and the Confidential Disclosure Policy. We had to appoint a compliance officer and a compliance committee. We have audit requirements. We have to submit an annual written report to the Centers for Medicare and Medicaid Services. Of course, we're providing training to thousands and thousands of Medicaid-relevant employees. We anticipate probably around 50,000 people or better that we need to train on an annual basis. And then we'll talk about the development of the state plan amendment, what the requirements are. That's also part of the compliance agreement. So the purpose or the goals of the compliance agreement are to remedy the consequences of past practices and policies and to ensure that those policies and practices are modified to achieve compliance. If the federal government comes in again and audits our program, we don't want to have to pay them back any money. That $541 million needs to be repaid over 5.5 years. Now, you're school business officials. I'm not, but I know that the state has no money right now, and that seems like an awful lot of money to have to pay back in a 5-year time period. So the purpose of the compliance agreement is to, explain to all of you what your documentation requirements are, how to be in compliance, and to know that if the federal government comes in again, that you're going to be okay. So I mentioned two policies that we had to adopt, New York State's policy regarding its commitment to ensure compliance. And basically, this policy is saying that New York State, the school districts, the counties, the 4201 schools, are going to comply with all federal and state regulations relating to billing Medicaid. The confidential disclosure policy informs employees how they can disclose inappropriate billing procedures. You may already have some sort of current policy in place on where your employees can go if they feel that there's fraud, abuse, or waste going on in your district. And if so, then this policy would just be added to your current policy. It needs to be posted somewhere. It needs to be made available to your employees, whether you put the confidential disclosure policy in a handbook, in your employee handbook, or you post it on your website someplace, or add to your current policy. As I said, that's perfectly fine. This is just a Reader's Digest version of the confidential disclosure policy. And again, if you check out our website, you can download these policies if you have not seen them. These two policies were sent to all school districts, counties, 4201 schools back in the summer. So everyone should be aware of these. We're going to talk about a compliance officer further on in this discussion, and it's pretty important that somebody have oversight of this program because for all of the trainings that I've done, as I just mentioned, these policies need to be shared with employees, particularly the confidential disclosure policy, which needs to be made available to every employee. Of all the trainings that I've done, nobody has seen these policies. So, as I said, with the OMIG compliance program, only those districts, counties that are billing in excess of $500,000 gross need to have a compliance program. We just feel it's best practice for everyone to adopt this program because who has oversight of your program? So Rose Firestein has been appointed the compliance officer. This is her contact information. Excuse me. When you read your confidential disclosure policy after our presentation this afternoon, I'm sure you're all going to run right to our website and download all of our handouts and check out these two policies. You'll see in the confidential disclosure policy this exact information that will tell you if you suspect any fraud, abuse, or waste going on in your district. You need to contact Rose in writing, and it will tell you how you can do that. So we'll talk a little bit about the OMIG compliance program. Effective October 1st, 2009, all districts and counties billing Medicaid in excess of $500,000 gross require a written compliance program. We talked about this already. There is a presentation by Robert Hussar, who is the Assistant Inspector General. There's also a webinar by Jim Sheehan, who is the Inspector General for the Office of Medicaid Inspector General. If you have questions and answers on the OMIG compliance program, I would urge you to visit this link, check out their website. They have a questions and answers section, as well as the webinar by Robert Hussar and Jim Sheehan. So these are the policies that need to be included in a compliance program. I'm sure every district and county out there billing in excess of $500,000 already has their compliance program in place. If you're below the $500,000, here are the elements that need to be included, and I won't go through all of them because, again, you would need to contact OMIG for further information or guidance. But if you look at question or element number 2, the designated compliance officer, I can't say enough that we just feel it's best practice for everyone, every district, every county to designate a compliance officer or someone at that level to have oversight of your program. We really want to shore up the School Supportive Health Services program and ensure that you have all the information you need, that your providers have all of the information they need to support every claim that you're going to be billing for. And if there are changes to this program, who will notify all of your relevant employees of those changes? As I said, we sent those 2 policies out, and of all of the trainings that I've done, no one, but maybe 1 or 2, have raised their hands to let me know that they're aware of them and have seen them. And that's policy that every employee should be made aware of. So just feel that it's really best practice to designate a compliance officer. It's very important. However, it's not mandatory if you are not billing in excess of $500,000. For those school districts and counties that are billing over $1 million, all of you will be audited on an annual basis, including New York City. For those that are billing $250,000 to $1 million, randomly audit 25 providers. And for those that are billing up to $250,000, OMIG will randomly audit 10 providers. OMIG has conducted their audit for the first time period, which was January of 2009 through June of 2009. So if you have not been contacted yet, you will not be contacted for that time period. I believe there was about 66 school districts and counties that were audited. The requirements can differ from one auditor to another. So one auditor might be asking from one school district, such as maybe attendance records, to compare those to the service records. Maybe another district might not have that set of documentation review from the auditor. But I just want to let all of you know that whatever your auditor is asking from you, you need to provide to them. So just keep that in mind, that they can ask pretty much for whatever they want, and you do need to provide that to them. And I'll give you an example of why. Some of you may have heard this story already, but there was a true case where a speech pathologist decided she wanted every Friday off, and she didn't think it was necessary to inform the district she was working for. So every Friday, she would tell the high school she was at the middle school, she would tell the middle school she was at the elementary, so on and so forth. And it was discovered after a year of doing this, the provider never worked a Friday in over a year. So luckily, when the district discovered this was going on, they contacted the Office of Medicaid Inspector General, and OMIG was at that district within the week and audited this provider's records. And it turned out that they were in compliance because the services were provided prior to 7/1/09, and for all services that were provided 7/1/09 or before that time period, it was based on a monthly billing cycle. So you only needed a minimum of 2 services per month in order to bill Medicaid. So they were lucky that it didn't affect the minimum 2 months by billing for Fridays that the service provider was never actually on the campus. So just keep that in mind, that the auditors have the right, and they are within their scope of auditing practice, to ask you for whatever documentation that they feel is necessary to complete that audit. Also, the next round of audits will begin in January of 2011, and they will be auditing claims paid in calendar year 2010. So I'm assuming at this point, it's almost November, that the audit will only cover the period prior to July 1st of 2009, since we are not billing for any services that have been provided effective the 10-11 school year at this time. But that could change. I mean, that could always open up tomorrow. Who knows? But they will be auditing claims paid for calendar year 2010, beginning January of 2011. Okay, so we pretty much discussed the OMIG audits. The independent audits, as part of the compliance agreement, we had to hire an independent auditor to test our internal controls. It could include a sample of claims from the districts and counties. We're not sure yet, or if they're just going to kind of review the OMIG audits. But if they do contact you, again, as I said, you need to provide the auditors with whatever information they're looking for. However, if these independent auditors come in and maybe find something that was lacking, some sort of documentation that was lacking, there would be no disallowances to you. They're checking our internal controls, not yours. So just please provide them with whatever they're looking for. And I'm not sure at this point in time if they will even be sampling any of your claims. The annual written reports need to be submitted to the Centers for Medicare and Medicaid Services, obviously on an annual basis. Our first annual report was sent to them already, and that will include all of our training. Our training program was included in that report, as well as all of our handouts. It includes how many relevant employees we think we have, as well as the number of relevant employees that have been trained to date. The written report also includes the audit findings from the Office of Medicaid Inspector General and any false claims that we might have received throughout the year and that were investigated. And I can tell you to date, we did receive one false claims accusation that we investigated and turned out not to be a Medicaid issue, but we had to forward that finding onto special education policy. So that also was included in the written report to Rose Firestein, or from Rose Firestein to the Centers for Medicare and Medicaid Services. we talked a little bit about the relevant employees that need to be trained. A few months back, we sent a notice out to all the districts, counties, and 4201 schools asking them to submit to us a list of all of their relevant employees. There's a link you can see in front of you. We do not feel that every district and county has done so thus far. So if you could check with your quote-unquote compliance officer or whoever in your district has oversight of this program to ask them if they have submitted that information to us. Our office staff will be reviewing our database shortly, and I say shortly because we are all on the road. It's a matter of when we can get around to it. But we will be reviewing that information hopefully soon and contacting any district that has not submitted information to us, or the districts and counties that we feel may have submitted the information but not all of it. I don't know if there's confusion, but I know some districts only submitted like 3 relevant employees to us, and that could be the business official, billing clerk, and CSE director. I'm really not sure, and maybe they didn't realize that the providers also needed to be included in the transmittal of that information. So if you could just check with someone at your district to find out if they have provided us with that information, and if not, there is a link to the form that needs to be completed for submission of that information. This training is annual. As I mentioned, we will be training face-to-face. You can check our training calendar on our website for dates if you're interested in registering, if you've not been certified already. And our face-to-face trainings at this time, we do not provide a certification for attendees. Our online training, at the completion of the online training, there will be a link for you to click on that will print a certificate for you. I think we are working on a certificate for the regional information centers to send to the attendees, the face-to-face attendees. I guess when we started this training back in June, we didn't think there would be a need for an actual paper certificate, but we found that people really are looking for that information as verification that they've attended this training, as well as use for any ongoing educational requirements that might need to be completed throughout the year. So we are working on a paper certificate, but at this time we do not have one. So we're pretty much done with the compliance piece of our training. I don't see that I have any questions here. So I guess unless someone sends me any question on the compliance, we'll get right into the guts of the state plan amendment. And we'll talk about what the covered services are, documentation requirements. We'll clarify the Medicaid billing and program policy. As I said, we've gone from a monthly based claim to an encounter-based claim. And then we have a few planning ahead topics to talk about. Usually at this point in the presentation, I'll ask if anybody knows what a state plan amendment is, and since you can't answer me, I'll just go ahead and tell you. A state plan is a comprehensive agreement between any state, all states, and the federal government that are billing Medicaid. And Medicaid is a health insurance program. So, I know there's been a lot of, not really discrepancy, there's been a lot of flexibility, I guess, for Medicaid billing because we're in the education environment. And the Medicaid policy unit used to be under the Office of Medicaid Inspector General, and I'm not sure exactly why, but as I mentioned, they're now full-fledged auditors, and the policy has been moved to the Office of Health Insurance Programs, who has oversight of the entire Medicaid program. So again, in order to be in compliance with the federal government's rules and regulations, we need to keep in mind that Medicaid is a health insurance program, and the documentation that is going to be required will be consistent with other Medicaid requirements in the early intervention, such as the early intervention program, teen pregnancy program, any other services that are out there in order to bill Medicaid. So most of the contents of the state plan have not changed. You need to establish medical necessity. The services need to be included in the student's individual education program. The services need to be provided by qualified professionals. And you need to keep appropriate documentation. So the bulk of the state plan requirements have not changed. What has changed is we now have clarification on qualified providers, and most of the qualified provider requirements have not changed other than we now have clarification on who can provide psychological counseling services. You probably remember in February of 2007, claims for psychological counseling services were pended based on determination from the Centers for Medicare and Medicaid Services on who could provide those services. So we now have clarification on who is a qualified provider to provide psychological counseling services and bill Medicaid for those services. And then the other change is the payment methodology. As I mentioned, for services prior to 7109, we were on a monthly-based billing system, and now we are going to be moving to an encounter-based. So for every service that's provided, you will bill for that service. One of the changes is, or also in addition to the changes, is the removal of targeted case management. Targeted case management was always in a separate spot, and it has been rescinded as of July 1st, 2010. The Centers for Medicare and Medicaid Services believes that true targeted case management is 24 hours a day, 7 days a week coordination. And it covers many services, not just educational services. It would include educational services, related services, as well as possibly scheduling doctor's appointments, arranging for transportation to those appointments, whatever services are needed for the student outside of the educational environment. And it could include setting up housing for the entire family. So the Centers for Medicare and Medicaid Services does not believe that true targeted case management is being conducted in the school setting. Therefore, that is no longer a service under the School Supportive Health Services program. And those services included the IEP reviews, the initial review, triennial, annual, and the amended requested review, as well as ongoing service coordination. So here are the 10 services that are included in the new state plan amendment. They're nothing new, the same services that have always been included, with the exception of the targeted case management. The State Plan Amendment 0961 has been moved from the rehab section of the state plan to the early and periodic screening, diagnostic, and treatment section of the state plan. And that means that Medicaid coverage of related services is only available until the student's 21st birthday. When the state plan was when the School Supportive Health Services program was under the rehab section of the state plan, it would be through completion of the school year that the child turned 21. Now it will be, now that it's under the EPSDT section of the state plan, the billing Medicaid for related services will stop once the student turns 21 years old. So I don't think, I'm not sure if you have handouts or not. I'm going to assume that you don't. We have a handout that is, looking for it. It's a provider qualifications and documentation requirements. And this handout lists each service and discusses what the initial requirements are, tells you that it needs to be on the IEP, who the approved Medicaid service provider can be, and the documentation requirements. And I'll give you an example for speech therapy services. The initial requirements are that you need a signed and dated written order or referral from a New York State licensed and registered physician, physician's assistant, a nurse practitioner, or a speech-language pathologist. A licensed and registered speech-language pathologist can write the referral for speech services. The written order or the written referral needs to be included in the student's record. You need to have an IEP. An IEP needs to be developed. A New York State licensed and a New York State registered SLP or a certified teacher of the speech and hearing handicapped under the direction of a New York State licensed and New York State registered SLP are qualified providers to provide those services. The documentation required to bill Medicaid are the evaluation. You need to have the evaluation. And you need contemporaneous session notes in order to bill Medicaid for each encounter. And contemporaneous session notes, there is a description of what that is on this handout, and it says the duties of the provider are discussed in Social Services Law. Providers must prepare and maintain contemporaneous records that demonstrate the provider's right to receive payment under the Medicaid program. Contemporaneous records means documentation of the services that have been provided as close to the conclusion of the session as practicable. And I'm sure you all know this already, but I thought I would just spell that out for you. So the services needed to be provided by a qualified provider. You need to have documentation of that qualification on file, whether it's the license, the certification, or registration. And services need to be provided by a New York State licensed registered provider acting within his or her scope of practice. So, as I mentioned, services for psychological counseling have been pended since February of 2007. We now have clarification as to who can provide those services, which is right in front of you. A psychological evaluation can only be provided by a New York State licensed and registered psychiatrist or psychologist. And then the psychological counseling services need to be provided by a New York State licensed and registered psychiatrist, psychologist, a licensed clinical social worker, or a licensed master social worker under the supervision of any of the three above. So a school psychologist can provide those services. We know that they're fully capable and able under their scope of practice to provide those services, and they can provide those services. You just cannot bill Medicaid if a school psychologist without a license to practice outside in the community is providing those services. And then here's just a summary of under the direction of and under the supervision of and who that applies to. We do have a handout also that you should take a look at in your spare time. It's more descriptive. Just to briefly review the under the direction of requirements would the provider providing the under the direction of would see the student at the beginning of and periodically. Thereafter, they would be familiar with the treatment plan and has continued involvement and directly supervises. They would assume professional responsibility, and they need to keep documentation supporting the supervision of services. The under the direction of applies to OTs providing service to, under the direction of, to OTAs, physical therapists providing service to physical therapist assistants, and speech SLPs, licensed and registered speech language pathologists, providing under the direction of teachers of the speech and hearing handicapped. The under the supervision of applies basically to the LMSW. The LMSW applies as the supervisor of the diagnosis and treatment. The cases are discussed. The supervisor provides at least 1 hour per week or 2 hours every other week of in-person clinical supervision. The supervising professional does not need to meet with the student at the beginning of and periodically. But basically, what we're saying here is the responsibility lies with the licensed professional to ensure what services are being delivered. So when you're looking at those CPT codes and the assistant is providing, putting a CPT code, maybe assigning a CPT code to the session notes, you need to make sure that those services were provided in accordance with what the session notes state, because it's your license on the line here. Or not your license, but the provider's license. We went through this slide already. So, I said Medicaid is a health insurance program. I think for a lot of school officials, they just look at Medicaid as additional funding, which it is additional funding to provide special education services. But the IEP, according to Medicaid, is not what establishes medical necessity. It would be the written order or referral. So School Supported Health Services Program is program services designed to enable a child with a benefit to assist with their special education services. The IEP determines what services are needed to receive a free, appropriate public education, and the written order or referral determines medical necessity. So, excuse me, here are the elements of what needs to be included on a written order or a referral. You need the name of the child, the complete date the order was written, the service that is being ordered, the provider's contact information, and they really probably should change this up a little. The provider's contact information is not the servicing provider. It would be the ordering practitioner's contact information. So the doctor who's signing the script, that's the information that they would be looking for here. And then you need their signature. You also need the time period for which services are being ordered, the ordering practitioner's NPI number or their license number. Either or is fine. And then the patient diagnosis and or reason or need for the service. And that's new. It's not new. It's new. It's not a new requirement in the Medicaid world. It's a new requirement in the education world. So I know a lot of districts and counties are going to lose out on billing for the 09-10 school year because they didn't have that patient diagnosis and or reason or need for services. Some actually were way ahead of the game, and I have heard from a couple of counties, I think because they're familiar with the early intervention program, that have actually required the patient diagnosis and or the reason or need for services on their written orders, but there's very few of them. And then a session note is required for each encounter or each service that is provided for the student. And the session note needs to include the student's name, the specific type of service that was provided, whether the service was provided individually or in a group, and specify the group size, the setting in which the service was provided, date and time, brief description of the student's progress, name, title, signature, and credentials of the person furnishing the service. And, we've been asked over and over if we were going to provide a form to the districts and counties on what a session note should look like, and I've been informed that we are not. As long as these elements are included in your session note, it really doesn't matter what it looks like. Just make sure that all of this information is included. And then other documentation requirements may exist under other programs. Quarterly progress notes are not going away, and parental consent, as far as we know at this time period, is not going away. So they are IDEA requirements, but they are still mandatory under special education policy. So you still need to adhere to what other requirements are out there. Okay, we'll talk about evaluations now. There's a handout for evaluations also. Not sure if you have that, but again, you can download that from our website. Basically, in the past, for services prior to 7109, if an evaluation was conducted, you could bill for it. Now, you could bill for an evaluation because you could bill for a student suspected of having a disability. For services effective 9/1, 09 and forward, the student needs to be classified as having a disability in order to be reimbursed for that evaluation. So if the student was not found to have a disability and there's no IEP developed, the evaluation cannot be reimbursed through Medicaid. If the student is found to have a disability, the evaluation must be listed on the IEP, must be provided by an appropriate, qualified, we actually have the flow chart right here. So we can go through this quickly. If the student's referred to the CSE, CPSE due to a suspected disability. Prior to the evaluation, was a written order or referral obtained from a qualified provider? If not, that evaluation is not Medicaid reimbursable. If so, if you have the written order or referral and a disability was identified and an IEP was established and the evaluation is reflected in the IEP, then that evaluation is Medicaid reimbursable. If you have the written order and a disability was not identified, it would not be Medicaid reimbursable. So just to summarize, evaluations must be reflected in the IEP. They assist with determination of medical necessity, and they must be provided by an appropriate qualified provider. So we'll talk about the payment methodology. As I said, we have gone to an encounter-based claiming methodology, where in the past, for services prior to 7109, that was based on a monthly rate-based claiming. So now we're going to be billing Medicaid for every encounter, every service that's provided to the student. Each service encounter must be documented through the use of session notes. A CPT code needs to be assigned to all claims. The fees for services were benchmarked at 75% of the 2010 Medicare fee schedule for the Mid-Hudson region. This is good for the rest of the state, and for the majority of us, you should see a slight increase in your reimbursement rates. However, New York City, in the past it was always New York City and ROS, New York City and rest of state. Now we're all one. So we will see an increase in our reimbursement, and New York City will see a decrease. Transportation continues to be billed using a cost-based methodology. We have probably over 100, close to 100, a little over 100 CPT codes that will be assigned to each service that is provided. These codes are timed and untimed. The OT and PT codes are generally in 15-minute sessions. They can be used interchangeably. There is a group code, one group code that will be used by OTs and PTs, and if I remember correctly, that code is 97150. And in the handout, it's assigned to, it says service type physical therapy, but keep in mind that occupational therapists will use that code for a group code as well. The session notes will determine what codes to use. So it will be the servicing provider that will assign a CPT code. Each provider should check their professional organization for most commonly used codes. And evaluations, and for evaluations, you can only bill once. Doesn't matter how long the evaluation process took, whether it took 2 sessions, 5 sessions. Basically, you're billing for the report that is generated, the outcome of the evaluation. So that will only be billed once, no matter how long it took. Okay, special transportation. You need to specify the nature of the student's transportation. Why is it special? What makes this particular student's transportation different than every other student? That needs to be specified on the IEP. What the other Medicaid reimbursable services are need to be listed in the IEP, whether they're getting physical therapy or speech therapy. And as I said, one-way rates have been established. In the past, you could only bill Medicaid if a student received a round-trip service. So if the school district, if he was picked up by the bus in the morning and then the parents picked him up in the afternoon to take him to a doctor's appointment or some other sort of an appointment, you wouldn't be able to bill transportation for that day. Now you can potentially bill 4 different transportation claims in one day, because if you pick the student up in the morning and transport him to school where he maybe gets a psychological counseling service, and then the student, you would be able to bill transportation for that trip because he received a service at the school. And then if the student's transported to another location outside of the school, say a BOCES or someplace else where he's getting speech services or occupational services, you would be able to bill for that transportation trip. Then the student's transported back to the school. That would be your 3rd transportation trip, and then back home. So you could potentially bill for 4 transportation trips in one day. You can only bill for special transportation on a day that a student receives a Medicaid-eligible service. And then at the bottom in the small print, it says, please note, regular transportation provided to preschool students is no longer Medicaid reimbursable. Special transportation, as described above, is available for both school-age and preschool students. So the same requirements apply to preschool students as they do to school-age students. So the requirements for submitting claims for services delivered before 7109 are that you would use the monthly rate codes. No CPT codes are required for those services. And it requires the supporting documentation that was in existence for that time period. We do have a handout that goes along with this slide. Again, you can download that handout from our website. But since you only needed a minimum of 2 services in order to bill Medicaid for services provided prior to 7109, you would only need to come up with documentation to support those 2 claims. Then for services delivered 9109 and thereafter, we'll be using encounter-based billing for the 10 services. It will require supporting documentation. The supporting documentation is a session note for each of those services, and the provider must identify services by the use of a CPT code. We're just moving right along here. Just to summarize, the documentation required to support your Medicaid reimbursement, services need to be included on an IEP. You need to have that written order or written referral. That's what establishes medical necessity. You'll document each service through your session notes. You need to provide documentation of your under the direction of or under the supervision of. Your provider credentials need to be kept on file. And then for special transportation, the need for special transportation needs to be included in the IEP. Your session notes for your other related services to document your special transportation. And you need to have your transportation logs. Retention documentation. For school districts and or for the purposes of Medicaid, you need to retain all documentation for a period of 6 years from the date of services. The date the services were paid, not the date the service was provided. And then just follow your employer's policy and or records retention and disposition schedule for disposal of documents. And for servicing providers, they may require, their professional organizations may require additional retention documentation. So they would need to, the servicing providers would need to check with their professional affiliations for more information on retention of documentation. Planning ahead. Planning ahead. In January of 2012, all servicing providers will be required to have an NPI number. On this slide, you'll see the link where occupational therapists, physical therapists, and SLPs can go to register for an NPI number. Just from experience from being out in the field training since June, we found that most providers, or quite a few of the providers, already have NPI numbers, so I don't think this will be an issue for any of the providers to get and to register their NPI number. I'm told it takes approximately 15 minutes. It is a free service. There will be no cost to the providers or the districts to have their providers obtain an NPI number. And also, probably around the same time period, it will be required to include an ICD-9 code on the written order or referral. And here's just a small example of an ICD-9 code. I think some districts and counties are already using ICD-9 codes, mostly counties. Again, through the EI program, they are familiar with these. It's a requirement already through the EI program, but probably will not become a requirement until January of 2012. additional resources you might be interested in. There's the Medicaid-in-Education homepage, the link to that. Also, Office of Professions is probably a good place for providers to go if they have questions pertaining to under the direction of or anything else affiliated with their profession, or they can refer to their professional organization's website for additional information, again, on under the direction of, under the supervision of, or most commonly used CPT codes. And here is our contact information. If you have any questions, I'd be happy to answer them. I don't know if anybody's alive out there. I haven't heard anything. I don't have any questions waiting for me. It looks like this is the end of our presentation, but if you find that you are reading through our policies and going through our website this afternoon or any other time, please do not hesitate to give me a call. So I guess this will conclude our webinar. Thank you all for joining me.
Thank you, Kelly. So I guess you're right. This concludes today's DIE Ryan and Associates webinar. Thank you all for attending. And I guess, someone just had a question.
How often, am I live right now?
Yeah.
Okay. So the question is, how often do schools have to check the provider list? I'm a little confused on which provider list you're talking about. Are you talking about the Office of Professions list of licensed providers that you employ, or are you talking about the provider exclusion list? The exclusion list. I can give you the information that I know, but I would refer you to the Office of Medicaid Inspector General's office and their website for more detailed information. But it is my understanding that the exclusion list should be checked every 30 days.
Okay, looks like we're all set with that question. Does anybody else have any other questions? Lori.
Let's see. Lori has a question on progress notes. We were told you have to put a progress statement in addition to the notes. I think I'm understanding that question. You need a session note for every encounter, for every session that you are providing to your student. So in the past, you only needed to provide progress notes probably quarterly. That's what the auditors would be looking for, and that's what you provided to your parents, to the parents that went out with the report cards. Progress notes are no longer a Medicaid requirement, only a special education requirement. Daily session notes are a Medicaid requirement. So for every service that you provide to a student, you will need a daily session note written on a contemporaneous basis that includes the elements that were laid out for you in one of the slides, and I believe you'll be able to view the slide. Does that answer your question? Oh, she's asking a statement such as progress, no progress, regression, limited progress. Yeah, it can be very vague. We understand that progress is not going to occur during every session you provide. So, yeah, they're looking for what type of progress was